luxation. Now, if you look at this view, if you look at this VD view, I want you to look at two areas. I want you to look at two areas first, and then you start looking at the rest of the pelvis. Number one, I want you to look at the sacroiliac junction. That's number one. And then I want you to go look at the coxofemoral joint. I want you to look at the coxofemoral joint. Because if you do such a wonderful job repairing pelvic fracture, and then you see that the acetabulum is fractured, the dog is not going to walk it. So an acetabulum fracture, sacroiliac. You need to look at those two first. Now the rest of them you can probably do. Do we care about an ischial fracture? Nah, because it's not weight bearing. Do you care about a pubic fracture? No, because it's not weight bearing. But articular and sacroiliac. Now, you can tell if a fracture of the ilium. That's easy. But I want you to look at the sacroiliac and the and the acetabulum. What do you think? What do you think? One of each? One of each. Look on the right side, look at the ilium. Come along the ilium and come right under the sacrum. There's a nice little line there. But look where you have to come under the sacrum and come all the way up. Notice where the ilium, you see where the ilium sort of juts out? That's where it attaches to the sacrum. And so you can use that as well. And then the right acetabulum structure. All the other fractures, fine. Because you're not going to repair the pubic and the ischial. Because once you repair those two, the pelvis is going to come back into its fairly normal position. Okay, cranial cruciate ligament. You're actually not going to get the instability by palpation. If you get that, perfect. But most of the time, what we see is joint effusion, hemorrhage in the joint. Cruciate rupture. Cruciate rupture. Look for joint effusion. If you have joint effusion, more than likely you got a cruciate rupture. And the cranial cruciate is most commonly involved. The osteophytes are secondary osteoarthritis. So what does that look like? Everybody see the osteoarthritis? Okay, good. So those osteophytes we see in the patella groove, along the patella, and along the tibia and femoral condyles. But that's, okay, normally, do you all remember the joint itself is coddled to the fat pad. The joint, the fluid. This is the fat pad, and the fat pad goes under the condyles. It's a triangular shaped structure and it's lucid. So if there is joint effusion, what's going to happen to the fat pad? It's going cranial. So there's cranial displacement of the fat pad. And if you see that, that tells you have joint effusion. You can make your diagnosis as cranial cruciate ligament rupture, or injury, or stretching, or something. Hip dysplasia. These are the radiographic findings. So for those of you where the owner comes in and want an evaluation for hip dysplasia less than 2 years of age, you may do that if you like. But if there's a case where there's just mild joint laxity, it can correct itself after 2 years of age. That's one of the drawbacks of trying to take films earlier than 2 years of age. A 1-year-old dog can appear to have joint laxity, like this one. So the femoral head should be within the acetabulum. 50% of it should be within the acetabulum. But how much do you have? Just a little snippet of it. So there's a lot of space in the acetabulum. So there's joint laxity, and And then on the left side is luxated, subluxated. And of course, a lot of joint space, but also very shallow. So those findings, hip dysplasia. Hip dysplasia. And so as it gets worse, you start seeing bone proliferation around the joint. And then you get secondary degenerative joint disease. Okay, question.
So we always take into consideration the age, right?
Say that one more time.
We're always taking into consideration the age.
Always take consideration of the age, absolutely, always.
We can't say I want you guys having this clinical findings.
If you see a 1-year-old with these findings, it has hip dysplasia. Okay, now if you have a 1-year-old that have mild joint laxity, you might not be able to call it because it's young. But when it gets to this severity, it's there. It's just going to get worse as it gets older.
So, one of the things that I've been trying to wrap my head around is like, okay, so we got OFA and we got PINHIP, right?
You have what?
We have OFA.
And you have, can you talk, and you have PINHIP?
PINHIP.
PINHIP, go to OFA.
So do OFA versus PINHIP?
Listen, that's me. That's me, that's just me. I don't want to bias you, that's just me. I'm just an OFA kind of woman. I'm not gonna hit on PINHIP. I'm not gonna. But I was trained at Michigan State. In Michigan State at Penn, they like this with that hip dysplasia stuff. Just an OFA kind of woman. So, but y'all do what you want. Both of them are good. Both of them are good. You pick which one you want to go to. Sorry, guys. Okay, so here we go. Here's joint laxity. I can only tell you what I'm used to. That's all I can tell you. But you can be an OFA kind of man. You must be from Pennsylvania. Okay. Who here from Pennsylvania? Oh. Okay. There's a lot of research on both of them. OFA has been around much longer. Okay, so here's an example of joint laxity. I just got to move. I think I have a couple more. And these are degrees of hip dysplasia. Okay, joint laxity. Look at the bone proliferation on the femoral neck. So why is the bone proliferation on the femoral neck? Because that's where the joint capsule attaches. So if it's not stable, what's going to happen? The joint capsule is going to pull. What's going to happen to the bone? It's going to proliferate. The femoral neck is going to be thickened because of the bone proliferation. And then over time, it just becomes just more and more severe. Primary bone tumor is a metaphyseal lesion. Metaphyseal. And we talk about at the knee and away from the elbow, right? But you can also have it distal tibia as well. It's a metaphyseal lesion. So if you saw proliferation on the femoral, if you saw proliferation and lysis on the femoral head, would you put primary bone tumor in your differential? No. But what would you put in there? You could put soft tissue tumor, like a synovial cell, or there's infection. So remember, infection, inflammation, is going to cause the bone to proliferate or lyse. It depends on where it's located. Metaphyseal lesion. Now, I prefer you to say primary bone tumor. Because can you say osteosarcoma from a film, an image? No. Because it could be a chondrosarc. So you're safe to say primary bone tumor. More likely, osteosarc. Because that's just an additional information that you can add. So if the primary bone tumor starts metaphyseal, as it grows outward, where's the periosteum going? It's going to move outward, a lateral. And this is what we refer to as Codman's triangle. It's a little triangle. It's where the periosteum is lifted and pushed away from the cortex. But couldn't that occur if you had osteomyelitis? Absolutely. So Codman's triangle does not say this is a primary bone tumor. All it's saying that is the periosteum has been shifted or moved laterally. These are other examples of osteosarcoma. This is a soft tissue tumor. Look how much bone lysis. Even if it's a digit, more than likely it's a soft tissue tumor. And then this is one that shows pulmonary metastatic disease. Aggressive bone disease. This is another one. That's kind of aggressive. That looks nasty, doesn't it? Kind of nasty. All right, so osteomyelitis would be definitely in your differential. And since it's not metaphyseal, you would think of a soft tissue tumor first. Wouldn't that work? Because that's not typical location for a primary bone tumor. And these are just more examples. Synovial cell, if it's in the joint, you would expect to see lysis at the distal part of both bones. Does primary bone tumor jump from bone to bone? No, it doesn't. So if you happen to see lysis distal femur, lysis proximal tibia, that's not a primary bone tumor. It doesn't jump spaces. It stays in one location and keeps it there. So the last one is HO, hypertrophic osteopathy. This is one where there's an original location, usually in the thorax. It can also occur in the abdomen, some chronic disease, and it causes palisade bone proliferation. And this is what it looks like. It's a beautiful pattern, palisade proliferation along the cortex. And it's usually multiple bones. Okay, not to be confused with HOD now. HOD is juvenile, double physis. HO's palisade proliferation, and usually it's in adults. So if you happen to see that, you need to go search for the primary, starting in the thorax. If you don't see anything in the thorax, then you go to the abdomen. If you don't see anything on the abdominal films, go to ultrasound. And if you don't see anything there, where do you go next? Not necropsy. Go to the brain or spine someplace. Okay. For the exam, I would like to have an exam Monday the 3rd or the 2nd. The 3rd. Do y'all have anything going on that Monday, the 2nd, 3rd, the 4th? The 2nd is on, no, the final is just going to be musculoskeletal. This stuff is going to be. The final actually is kind of easy. That's why I'm trying to get all this other stuff out of it. So, because you're going to be having so many exams, and so for radiology, just like the stuff I'm covering, and look how we do some kind of review or something. For the final. But we got to get one more exam, which is going to be abdomen and ultrasound.
Can we have them 30
You may have it anytime you like. You want to have it on the 30th? The 30th, look at your calendars. And then that saved you all a trip from trying to answer class. So I can go ahead and finish it. November the 30th?
Yes.
November the 30th going once?
Let's do that.
November the 30th going twice? November the 30th? All right, bye.